Jumping straight in, the following simplified symptoms constitute major depressive disorder, MDD, in the Diagnostic and Statistical Manual of Mental Disorders, or DSM. Depressed mood, markedly diminished interest or pleasure, significant weight loss or weight gain, insomnia or hypersomnia, psychomotor issues, nervous or intense movement or slowed movement, fatigue or loss of energy, feelings of worthlessness or guilt, diminished ability to think, recurrent thoughts of death. No matter the context for these symptoms, the most recent edition of the DSM encourages clinicians to give a diagnosis, to label the individual who is experiencing at least 5 of these symptoms for 2 weeks as abnormal, that is to say, as having diseased thoughts or behavior. From the DSM-5. Responses to a significant loss, such as bereavement, financial ruin, losses from a natural disaster, a serious medical illness or disability, may include the feelings of intense sadness, rumination about the loss, insomnia, poor appetite, and weight loss noted in Criterion A, which may resemble a depressive episode. Although such symptoms may be understandable or considered appropriate to the loss, the presence of a major depressive episode, in addition to the normal response to a significant loss, should also be carefully considered. And of course, a single major depressive episode constitutes MDD. Despite the narrowly defined bereavement exclusion, which was included in the DSM-3 and the DSM-4, but was removed from the DSM-5, these same symptoms have persisted since 1980. Although originally developed by expert committee, in which disputes favored the loudest or most determined expert, they have constantly been presented as medically or scientifically based. And here I will read points from a couple of articles before introducing the work of another key psychiatrist, Alan Francis, with her DSM-5, the British Journal of Psychiatry, 2009. Alan Francis was chair of the DSM-4 task force, and it is his eyewitness testimony that I have consistently emphasized to highlight how messy a process the development of symptomatic criteria was during work on the DSM-3. Well before the formal start of work on DSM-5 in 2007, the American Psychiatric Association, with support from the National Institute of Mental Health, attempted to develop a research agenda that would support the development of a classification system in psychiatry based on biological markers. Not surprisingly, the disappointing conclusion of all this effort was that there are no biological markers even remotely ready for inclusion in DSM-5. It is obvious that our field lacks the fundamental understanding of pathogenesis that will be required before we can take the next meaningful step forward towards a paradigm-shifting etiological model of diagnosis. Jeffrey Lacasse, after DSM-5, A Critical Mental Health Research Agenda for the 21st Century, Research on Social Work Practice, 2014. All problems defined in the DSM-5, from adjustment disorder to sexual problems to shyness, are just claimed to be medical. This factual assertion takes place in the context of the well-documented fact that there are no biological tests, markers, or well-controlled studies identifying a biological lesion for any mental disorder classification. The DSM-5 uses confused wording on this issue, stating that a mental disorder is a syndrome, and elsewhere arguing disease. Elsewhere arguing that a mental disorder is disease. Thus, according to the developers of DSM-5, mental disorders are both syndromes and diseases, conflating two terms with importantly different meanings in medicine. Syndromes being the minimum, non-random, consistent grouping of observations necessary to hypothesize possible medical diseases. To validate a syndrome as a disease, objective physiological markers must be found. Looking at the etiology of Rett's disorder and its treatment in the DSM-5, Lacasse also emphasizes the DSM-5, or just the DSM including all of its additions, only includes mental disorders for which we lack information regarding etiology, which may or may not turn out to be diseases in the long run. But if their etiology is discovered, confirming that they are diseases, apparently they cease to be mental disorders, although the DSM also claims that mental disorders are diseases. Decades earlier, psychiatrist Thomas Szasz wrote about this same topic in his book, The Myth of Mental Illness, originally published in 1961. This is from the revised edition published in 1974. The invention of the mental illness. Until the middle of the 19th century and beyond, illness meant a bodily disorder whose typical manifestation was an alteration of bodily structure. That is, a visible deformity, disease, or lesion, such as a misshapen extremity, ulcerated skin, or a fracture or wound. Since in this original meaning of it, illness was identified by altered bodily structure, physicians distinguished diseases from non-diseases according to whether or not they could detect an abnormal change in the structure of a person's body. This is why, after dissection of the body was permitted, anatomy became the basis of medical science. By this means, physicians were able to identify numerous alterations in the structure of the body which were not otherwise apparent. As more specialized methods of examining bodily tissues and fluids were developed, the pathologist's skills in detecting hitherto unknown bodily diseases grew explosively. Anatomical and pathological methods and criteria continue to play a constantly increasing role in enabling physicians to identify alterations in physicochemical integrity of the body and to distinguish between persons who display such identifiable signs of illness and those who do not. It is important to understand clearly that modern psychiatry and the identification of new psychiatric diseases began not by identifying such diseases by means of the established methods of pathology, but by creating a new criterion of what constitutes disease. To the established criterion of detectable alteration of bodily structure was now added the fresh criterion of alteration of bodily function. And as the former was detected by observing the patient's body, so the latter was detected by observing his behavior. This is how and why conversion hysteria became the prototype of this new class of diseases, appropriately named mental, to distinguish them from those that are organic, and appropriately called also functional, in contrast to those that are structural. Thus, whereas in modern medicine, new diseases were discovered, in modern psychiatry, they were invented. Paresis was proved to be a disease, hysteria was declared to be one. It would be difficult to overemphasize the importance of this shift in the criteria of what constitutes illness. Under its impact, persons who complained of pains and paralyses, but were apparently physically intact in their bodies, that is, were healthy by the old standards, were now declared to be suffering from a functional illness. This was hysteria invented, and thus were all the other mental illnesses invented, each identified by the various complaints or functional behavioral alterations of the persons affected by them. And thus was a compelling parallel constructed between bodily and mental illness. For example, as paresis was considered to be a structural disease of the brain, so hysteria and other mental illnesses were considered to be functional diseases of the same organ. So-called functional illnesses were thus placed in the same category as structural illnesses and were distinguished from imitated or faked illnesses by means of the criterion of voluntary falsification. Accordingly, hysteria, neurasthenia, depression, paranoia, and so forth were regarded as diseases that happened to people. Mentally sick persons did not will their pathological behavior and were therefore considered not responsible for it. These mental diseases were then contrasted with malingering, which was the voluntary imitation of illness. Finally, psychiatrists have asserted that malingering, too, is a form of mental illness. This presents us with the logical absurdity of a disease which, even when it is deliberately counterfeited, is still a disease. But clearly, this is the inescapable consequence of confusing discovering diseases with inventing them. The enterprise of trying to discover bodily diseases, constrained by fixed criteria and the requirements of empirical evidence, cannot eventuate in the conclusion that every phenomenon observed by the investigator is a disease. But the enterprise of inventing mental diseases, unconstrained by fixed criteria or the requirements of empirical evidence, must eventuate in the conclusion that any phenomenon studied by the observer may be defined as a disease. Thomas Sauss, The Myth of Mental Illness, 50 years later, 37 years from the publication of the revised edition. 50 years ago, it made sense to assert that mental illnesses are not diseases. It makes no sense to do so today. Debate about what counts as mental illness has been replaced by political judicial decrees and economic criteria. Old diseases such as homosexuality disappear, whereas new diseases such as attention deficit hyperactivity disorder appear. 50 years ago, the question, what is mental illness, was of interest to physicians, philosophers, sociologists, as well as the general public. This is no longer the case. The question has been settled by the holders of political power. They have decreed that mental illness is a disease like any other. In 1999, the U.S. President Bill Clinton declared, "Mental illness can be accurately diagnosed, successfully treated, just as physical illness." Surgeon General David Satcher agreed, "Just as things go wrong with the heart and kidneys and liver, so things go wrong with the brain." Thus has political power and professional self-interest united in turning a false belief into a lying fact. The claim that mental illnesses are diagnosable disorders of the brain is not based on scientific research. It is an error or a deception or a naive revival of the somatic premise of the long discredited humoral theory of disease. My claim that mental illnesses are fictitious illnesses is also not based on scientific research. Rather, it rests on the pathologist's materialistic scientific definition of illness as the structural or functional alteration of cells, tissues, and organs. If we accept this definition of disease, then it follows that mental illness is a metaphor. Asserting that view is stating an analytic truth, not subject to empirical falsification. The bottom line is, there is no scientific evidence to support the claim that any mental illness is a medical disease. In psychiatry or psychology, practice does not equate to medicine. Again, from The Myth of Mental Illness, the book. My first task, accordingly, is to present an essentially destructive analysis of the concept of mental illness and of psychiatry as a pseudo-medical enterprise. I believe that such destruction, like tearing down old buildings, is necessary if we are to construct a new, more habitable edifice for the science of man. The problem is that the mental health industry has been able to keep up the facade. It has presented mental illness as medical disease for decades and continues to do so today. It constantly sweeps this and other related issues with the industry under the rug, at least in part through the continual revision of the Diagnostic and Statistical Manual of Mental Disorders, with the narrative that each subsequent edition solves the major problems of psychiatry's past or yesterday. Upon examination of these claims, of course, it's always too late, and the profession is in the process of moving on to the next set of issues. And I will leave it off until next time. I hope to see you there.